For example, a tongue lesion in the tip would have had a skip lesion in the submental region. So whether these are two tumors, primary tumors, or whether it's the same tumor that has a different extension is what was the confusion. Now they have clarified it by saying that if there is a soft tissue deposit and if that shows tumor in it, if it is in the site of regional lymph node, you call it stage it as lymph node. Confusion is clear. So tongue lesion, there is some deposit in 1A region submental. It doesn't show lymph node tissue at all in pathology. It is entirely tumor, yet it is in the site of a regional lymph node, correct? Now this can be called only as a lymph node metastasis and nothing else. So that is another final clarity that we have got, and this is where our contribution has been recognized by AJCC. So like I said in the first slide, India is picking up for the world now. What these guidelines tell us is something from, it is all by the ethnicity of European and Americans, Western ethnicity. In our population, when there is any oral cavity or head neck malignancies, when there is extensive perineural invasion or worst pattern of invasion is 4 or 5, we felt that, we have noticed that these patients recurred bad than expected. So to decide on adjuvant treatment in any head neck cancers, there are only 2-3. It's not rocket science. Anything above T3, you have to give radiation. Any node positive, you give radiation. Now, we are talking about PT2N0 with extensive perineural invasion and worst pattern of invasion. By guidelines, by book, you need not give radiation, because you don't have the risk factor. It's T2, it's stage 2. One modality of treatment is sufficient according to the earlier guideline. Now it has been added as a soft indication that extensive perineural invasion, worst pattern of invasion, and other factors may be the decision making factor even if it is stage 1. So by rule, even if it is T1N0, small 1 centimeter tongue lesion we have excised, if it has extensive perineural invasion, high worst pattern of invasion, we are radiating the patient. It may be over treatment. That is what was the debate. But then the outcomes after seeing around 260 patients, it favored. The addition of radiation helped in delaying the recurrences. So moving ahead, these are all the clinical pictures of my patients. Sorry if it looks gory. This was in 2025. Do we accept this as a good quality of life? He has had 2 pectoralis major flaps, PMMC, pectoralis major myocutaneous flaps. We have reconstructed. This is a 4th time recurrency. It may be applicable in certain rare scenarios, but then this cannot be the norm today. This patient is a different story, but then I just wanted to show this to say that this is not the quality of life that we are aiming at or we are looking at now. So this is a deltopectoral flap because a free fibula failed for him and he had a submental defect and we put a deltopectoral flap. This is a 4th recurrence patient actually. We had to take bilateral PMMC along with and this PMMC had to be taken outside and it was and mind you, this patient is still alive. So now we are going through the surgical part of the presentation. We will cover all the subsites of the oral cavity, starting from the lip. So some elderly gentleman, bad lip lesion, lower lip almost 2/3 is involved, upper lip was involved up front, and even now this is after radiation. You can see the post-radiation changes in the skin, and even now there is induration up till here in the upper lip, about half of it. So this was the resected post-resection. Almost 2/3 of the lower lip is gone. Almost 1/2 of the upper lip is gone. Now these patients will have, anybody can reconstruct with anything in this now. You can put a PMMC. You see in oncology you can have debate on every topic. You can get evidence for and against on anything. But then for quality of life there is no debate. So for this patient, what we have done is we've taken an ALT facial atta sling. This is the facial atta from the thigh. We harvested facial atta, then used it as a sling, fixed it to the orbicularis oris on the remnant left side of the fixed it to the mandible here, to the commissure as an annulus, and then fixed it to the remnant upper lips orbicularis oris. Now what it does, and then over this we have put a free radial artery forearm flap. Now what it has done, I know it is bulky flap, but then this can be corrected later. The video is not coming. So what we could achieve in this patient is that commissural competence, which is a significant factor here. So when he drinks liquids, there is no drooling of the fluid, there is no drooling of the food, there is no dripping. He is able to communicate, he is talking well, and he is eating well without any issue. Once they get a good disease-free survival, let's say 2 years to 3 years, they don't have disease progression, we will go in again, debulk this flap and give it a cosmetically good outcome as well. Now it is a functionally good outcome. Eventually, once the disease stabilizes and the prognosis looks fair, we can debulk that flap and make it look good as well. Now, moving from the lip, we're going now into the tongue. From wide excision glossectomies for small lesions with a centimeter margin to hemiglossectomies or partial glossectomies to near total and total glossectomies, we do everything and reconstruct, preferably only with a free flap. Now this is a hemiglossectomy done, large proliferative growth on the right side of the tongue, resected, neck dissection done, and then replaced with a free radial artery forearm flap. No tracheostomy because it was a small resection, and fairly we were confident with the vascularity, we could avoid tracheostomy. Now another right lateral border tongue lesion, again wide excision done, replaced it with a hemiglossectomy done, and replaced it with a radial artery forearm. Neck dissection clips are seen here. Now this is entire hemiglossectomy extending into the base of the tongue and resection of soft palate also. We have closed the soft palate primarily and then put a ALT flap and created the entire bulk of the tongue. This part of the tongue will help in moving if you anchor it properly. If that flap insert is given properly, this will become mobile as well. So if you don't insert it to the mandible, definitely this part of the flap will move, and that is what we do. The remnant tongue will take over and help in mobility of the flap as well as the tongue and aids in oral feeding as well as speech. Another tongue, one half of the tongue is taken off, replaced it with an ALT because he had a fracture in one arm and a fungal infection on the other arm. Young man, we replaced it with an ALT, and henceforth extra bulk is there, which eventually will settle. So we have seen lip, we have seen tongue. Now various types of tongue glossectomies to near total glossectomies. Now this is floor of the mouth. Some ulcer was there here. We have removed the specimen here. The arch was removed, and this was only marginal mandibulectomy. You can see the remnant mandible here, and the ulcer is here. This is the defect. We replaced it with only a small free radial artery forearm flap. Now if you have seen this, we have not violated the oral commissure, or there is no scar in the face here. So this approach is called Weiser approach, wherein we put a full transverse neck skin crease incision from this angle to the other angle, lift everything up from down, go up, pull everything down, remove the tumor, put the flap inside, insert, anastomosis in the neck, done. So this is probably what you refer as most of the time as well, ameloblastoma. So protruding jaw, multicentric extensive lesion, angle to angle, from the angle of the ipsilateral to the contralateral angle of the mandible, it has been resected. We put a plate, reconstructed with a free fibula with a myocutaneous flap as well, and covered the floor of the mouth, floor of the mandible. So this was before surgery. We could correct the prognathism as well by properly aligning the plate, and this is after surgery. This is immediately after surgery with a tracheostomy tube, and once in follow-up, the scars are not seen. That's the beauty of midline lip split incisions. They just merge and they disappear most often. And all the resections need not be extensive. Buccal fat pad is a blessing in disguise for you as well as for us. So it can provided if we properly harvest the buccal fat pad without aggressively mobilizing it and making it devascular, it is one robust flap. It will reach palate, it will reach retromolar trigone region, it will reach tongue and everywhere. So this is a small buccal mucosal lesion excised and just placed intraorally, placed a buccal fat pad, removed neck lymph node dissection was done, and then discharged on day 3, day 4 without any tracheostomy tube on oral diet. This is an extensive case again. Preoperatively, our pathologist gave this as mucoepidermoid carcinoma of the floor of the mouth. So entire anterior two-third tongue was involved, floor of the mouth was involved. It is, if you can see, if it is reaching the mandible to the other side of it, as well as it is reaching the skin in the submental region as well. Mucoepidermoid carcinoma, there is no treatment, nothing works. High-grade mucoepidermoid carcinoma, if we give radiation also, nothing works, bone is involved. So young man, we went ahead with the surgery. Then this is a resection. We did a step cut here because the tumor was not, if you have noticed, we did a step cut of the mandible on one side just to preserve the length of it. We did double free flap for him. So this is ALT with two perforators. ALT from the thigh, anterolateral thigh flap, with two perforators here. This was used to reconstruct the tongue and the large defect in the floor of the mouth. Now, the mandible was replaced with a free fibula and its own skin and muscle paddle. So we created a tongue, we folded the ALT, we made it in the shape of a tongue,